So hi, everybody. I'm so excited to see everyone here for our fifth webinar in our series. This is Communicating Data for Action, helping people find, understand, and use public health data. And we've got a couple guest speakers today, colleagues from Cook County Department of Public Health. I'm really excited to share the presentation with. And for anybody who's just joining here, there's a QR code there, so you could use your phone photo app to scan that, or you can type in that short web address. That takes you to sort of a back resource page. It has a bunch of links and information and all that kind of stuff. So we'll refer to that. It'll be popped up on the next page as well, and then also at the end of the conversation or the end of the presentation. So no worries if you miss it right now. Next slide, please. All right. Oops. So there's that QR code again if you still need it. So for about the first hour, more or less, we're gonna talk at you a little bit. This part's gonna be recorded, so we do have it so that you can't come off mute or come off camera. And we're not going to take questions during this portion. We're going to be covering numeracy and why people struggle to understand data. We're going to go over 3 strategies for communicating data, and then we're going to go through some CCDPH tools and real-world applications. After that, there is the Q&A open, so feel free to enter questions at any time during the Q&A or into the Q&A part. And then after that, we will stop the recording and do a question and answer session, and that part is not recorded, so feel free to stay on and have a discussion with us afterwards. All right, next slide, please. Here's some goals for today. We want to recognize the importance of sharing data in plain language. We want to identify key considerations for communicating data to different audiences, describe ways to improve how you communicate data with your stakeholders, and identify data resources offered by Cook County Department of Public Health. Next slide, please. For anybody who's joining us for the first time, welcome. I'm Dr. Darcy Moeller. I'm a medical officer at Cook County Department of Public Health, as well as the program director for our Public Health and Preventive Medicine residency program, and I lead our health literacy initiative. Next slide, please. And as usual, we're going to begin with super brief overview of the initiative, just so that we're all starting from the same place. Next slide. All right, our Health Literacy Initiative is focused on organizational change based on the principles of organizational health literacy. And organizational health literacy is defined as the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Next slide, please. If you haven't already, I encourage you to visit healthliteratecookcounty.org. You're going to find our organizational health literacy toolkit there, recordings from all the previous webinars, and additional tools and resources that have sort of accompanied or been released with each of the webinars. And as always, everything that we reference today is going to be included in that resource document that will put the QR code again at the end of the webinar. Okay, let's get into it. Next slide. So today we're going to talk about something that concerns just about everyone working in public health, which is how do we communicate public health data in a way that people can actually use? And we're going to start by talking about understanding data. Next slide. So first, let's take a minute to address why this topic matters. In public health, we invest tremendous time and energy collecting, using, reporting on data, and we share data with many audiences and for many purposes. We have data dashboards that are communicating local health indicators, surveillance reports, countless different types of presentations, and even things like grant proposals. I pasted the organizational health literacy definition there again to highlight that at its core, as health literate organizations, we are helping folks to find, understand, and use information, and data is included in that. We're going to cover a little bit of finding data later in this webinar, but for now, we're going to focus on enabling people to understand. We often imagine a process that looks something like the graphic on the left there. So we present the data, and that leads to some desired action. If we show people that we are increasing rates of some infectious disease, then they're going to get vaccinated. Or we show people that air quality data, and they're going to choose to stay indoors. We provide data on overdoses in our grant application, and the grant will be funded. But that's not really that simple. Next slide. So we have to consider the audience, and it can be helpful to really think about them as each person as an individual. Between the data and the action is a person. So a person that has to figure out what the data is, they have to determine what the data means. It's likely that they will have some feelings or emotions about that data, and then they need to decide whether or not they're going to do anything with the information. Um, every choice that we make when we're communicating the data influences that process. And, I will come back a few times to this phrase, but there's a common phrase that you'll hear that people say, which is the data speaks for itself. But that's really never true. Um, in particular, how we present data greatly impacts how it is interpreted, understood, and how it makes people feel. And communicating data really comes with special challenges, which we're going to get into a little bit now. Next slide. So what makes numbers so challenging? And even more so challenging than text. So first, numbers are abstract and they require active mental processing. So if I say dog, your brain just immediately activates the concept. There's essentially no delay, no processing time needed for you to know what I'm talking about. Um, Small whole numbers that are coupled with words are fairly straightforward as well. So, for example, things like 2 children or 5 bananas. But um, unlike words, numbers on their own are abstract. So that's to say that they don't have any meaning. If I say 17.3, your brain has to ask 17.3 of what? Is that large? Is that small? What is that? So the number doesn't have meaning on its own. Second, using numbers often relies on limited working memory. Working memory is the temporary information that you actively hold in your mind just for a short time to conduct some tasks. So, for example, you're reading a phone number from a billboard and you want to remember it long enough just to save it in your phone. Um, you can only hold so much of that information, so much information in your working memory at any one time, actually very little information. And often to make sense of the numbers that we're presenting to people, they really need to use their working memory. So things like comparing the incidence of one health indicator to another, remembering the value from like one graph to the next, converting percentages into a number of people that it represents. We really ask a lot of working memory. And third, we use mental shortcuts to quickly make sense of numbers. So people don't literally calculate everything. We're not like human calculators thinking of calculations and math in our heads every time we see numbers. We use shortcuts and we estimate. And most of the time, those shortcuts are incredibly helpful. They allow us to make quick decisions without having to stop and do math all the time whenever we see a number. But those same shortcuts can lead us astray, especially when the numbers are presented in ways our brains weren't designed to interpret. So let me show you what I mean with a little example. Next slide. This is a famous example of one of those mental shortcuts. So back in the 1980s, A&W restaurants wanted to compete with the McDonald's Quarter Pounder, and they introduced a 1/3 pound burger. Now, by almost every measure, this burger should have been a success. It was larger than the Quarter Pounder. People preferred it in taste tests, and it was the same price. And A&W invested heavily in marketing this burger, but it really flopped. And so then they hired a market research firm to conduct focus groups. And what they found was that despite 1/3 being larger than 1/4, many people thought it was the other way around. So some people had even said, why would I pay the same price for 1/3 of a pound that I do for 1/4 of a pound? Um, so, when I hear this story, I do think that it's likely that some of those people would realize their error if they were asked to do a calculation, and really asked, a math problem saying is 1/3 or 1/4 larger, but their brains made a quick judgment just based on what they saw. and it led them to the wrong answer. So, I think the takeaway is that we can't assume that people are going to interpret numbers the way we expect them to. Next slide. So numeracy is the ability to understand and use numbers and math in everyday life. The ability to understand and work with numbers is often referred to as numeracy. Like health literacy, there isn't one universally accepted definition. So this is sort of my general definition that I use. Also, like health literacy, we prefer to focus on what we can do as organizations to enable folks to understand our numbers and data. But it can be helpful to get a sense of an individual's numeracy skills. Next slide. So based on that, how are adults in Cook County doing? The data on this slide comes from the Program for the International Assessment of Adult Competencies. It's a large national study that measures adult literacy and numeracy skills and allows estimates at the county level. So you can see level 1 is considered at risk for numeracy difficulties. So this group includes a range of skills, with those at the top of the range being comfortable with basic arithmetic, so addition, subtraction, some multiplication or division, but struggling with percentages, fractions, or interpreting graphs. Level 2 is nearing proficiency, but still struggling to perform numeracy tasks, and includes people who can work with things like decimals, percentages, charts, and tables, but may have difficulty when problems are more complex or unfamiliar. And then level 3 includes those with the highest numeracy skills who are proficient at working with mathematical information and can understand more complex data. So you can see that in Cook County, about 1/3 of adults fall in each category. And practically, what that means is that if you're presenting to a room of 100 people in Cook County, on average, somewhere around 33 of those people may struggle with even basic numerical concepts that we are using routinely in public health. Next slide. We don't have neighborhood level data on numeracy. So I'm using high school graduation rates here as a very rough proxy. Of course, there's a lot of things that go into high school graduation rates. The data here is from our Suburban Cook County Health Atlas, which you will get to see later in today's session. If we just look at Suburban Cook County as a whole, the average high school graduation rate is about 90%, but you can see that rates vary considerably from one community to another, and some of those are highlighted there. So we could have a whole webinar that's dissecting why we see these differences across our communities, which isn't really the point of this webinar, but suffice it to say that the takeaway from this data should be that our communities have different strengths, different opportunities, and different resources. And when it comes to numeracy, that's no different. And we need to consider how improving our communication of numbers and data can increase equity. Next slide. So today I'd like to share 3 ideas that I find myself coming back to over and over again whenever I'm preparing a presentation or writing a report or really communicating data in any way. This is absolutely nowhere near comprehensive, so there's a lot of stuff that's not included just for time, but just giving you guys some high-level ideas and to get the conversation started. Next slide. So the three things that I'm highlighting here: number 1, know your audience and goal. Number 2, reduce complexity. And number 3, provide context. Next slide. So let's start with our first principle: know your audience and goal. Who is this for? So is your audience community members, partner organizations, participants in some program, policymakers, leadership at your own organization? As you know, different audiences come with different background knowledge, different questions, different levels of comfort with data, different reasons for caring even. If I'm speaking with epidemiologists, they're going to be more comfortable with advanced numerical concepts, and in fact are probably going to prefer that I use those, right? So we can have an in-depth discussion. But if I'm speaking directly to members of the public, I'm going to be much more selective about the type of data that I share. And so you also have to ask, why am I sharing this data? What do I want them to do after seeing this information? So Are you trying to inform or to provide a warning? Do you want to support a decision that someone needs to make? Celebrate the progress that you've made, advocate for funding. Coming back to that common phrase, the data speaks for itself, and how that's not true. The exact same data can be presented in different ways that really changes how people will interpret, understand, and feel about it. So one thing that I want you to remember is that there's really no such thing as neutral data communication. Every choice that you make has an impact, whether or not you're aware of that impact. Next slide. So as I said, we don't have time to be at all comprehensive here, but I did want to make sure that the webinar gave you guys at least a few good actionable tips for each of these sections. So here is one. This is an example of how interpretation of probability can be impacted by how you present that probability. So the categories that are on the left there, very common, common, uncommon, rare, very rare, these were designed by the Council for International Organizations of Medical Sciences. They were adopted by the EU. They're intended to be used, the idea behind them was to standardize and clarify risk communication across Europe, but several high quality studies suggest that these verbal terms can lead to overestimation of risk. So when verbal descriptors are used instead of numbers, so instead of the numbers on the right or in the middle, people perceive the probability to be higher and or the negative consequences to be higher than if they use the numbers. So I'll just give you an example. Telling someone that a side effect is rare makes them imagine that they have somewhere in the range of a 9% chance of having that side effect, even though rare is intended to communicate like a 0.01 to 0.1% chance. So if you want to trigger some of those interpretations, you may choose how you want to present the data. In public health, we're often more focused on informing, and to inform, the most accurate risk perceptions come from examples on the right there. So for rare, you would want to say something like up to 1 in 1,000 people. Depends on what you're talking about to actually adjust the numbers, right? But you'd want to say something to that effect. So if you're trying to convey risk, don't be afraid to actually use numbers. Next slide. Just another example of how you present data impacting its interpretation. Here we have the same data presented in two different ways. So using absolute risk and relative risk. So both of these statements are completely accurate and equivalent, right? They're describing the same study, the same data, but they don't feel the same at all. So a 33% reduction sounds much more impressive than a 1 percentage point reduction, even though mathematically we're saying actually the same thing. So what's interesting is that consciously or unconsciously, I think probably both, in both medical literature and in common media, we all tend to use relative differences when we're talking about the benefits because we like to magnify the benefits, and we tend to use absolute differences when we're talking about risks. When you actually pay attention to this, you'll notice this in things that you read. So if you want to help to inform people about the size of an effect, you're going to want to choose absolute risk. If your goal is to persuade, you might choose to use relative risk because it appears larger and feels larger. Next slide. Okay, our second principle is reduce complexity. So reducing complexity does not mean dumbing things down or removing important context or information. It means reducing the amount of work your audience has to do to understand what you're trying to communicate. So as we've talked about, understanding numbers already takes more processing power than understanding many other types of communication or information. So whenever we can remove that unnecessary work, we're helping people to focus on what actually matters. So if you imagine your audience has a limited amount of processing power available to them, most times some of that processing power is already being used, right? They could be stressed. They could be reading your report between meetings. They could be worried about a sick family member. They could be exhausted, right? There could be a lot of things going on in their environment that are, wearing them out, so many different things. So they only have whatever is sort of left in their brains, so whatever's left of their processing power to dedicate to understanding your data. So if you think about every unnecessary label, every additional graph that you add, every distracting color, etc., if you think about that as asking your audience to spend processing power on those things, you know, and understanding that some of those things aren't helping them to understand, right? So remember that less is often more. We get really excited when we're sharing our work, and it can be so tempting to feel the need to include more detail and more context. And we actually often feel uncomfortable when we're leaving something out, like our audience is going to miss it, or it's important, or they have to know, or they have to know that I know. But just remember that everything you include comes at a cost to some amount of processing power. So one thing that a question I'll ask myself when I'm presenting things is, if someone remembers only one thing from this, what do I want that to be? Sometimes the most helpful thing that we can do is decide what not to include because it's competing with your main point for the attention. And this includes also things like reducing visual clutter. You don't need to add a bunch of like fancy flair to your graphics. You want to use clear, easy to read labels with good color contrast in a large enough font size. You want to avoid making people jump back and forth between legends or keys and figures. You want to highlight the parts of the graph or the table or the data that actually matter to help guide their eyes. But you want to keep it as sort of simple as and distraction free as possible. Next slide. This is just a good reminder for this section about the curse of knowledge, which is that once we know something, we find it hard to imagine what it was like to not know it. If you are presenting any data, you're likely very familiar with that data. And so you really are not the right person to know if it's clear or not. So have someone else look at it and offer their opinions and even talk it through with you. What's clear, what's not clear. Next slide. And again, nowhere near comprehensive, but just to give you a few tips on reducing complexity. This is tips about reducing complexity related to numbers, specifically having to do with whole numbers. Whole numbers in general are easier to compare. People can intuitively compare 5 milligrams versus 10 milligrams much more easily than 0.5 milligrams versus 1 milligram. Even though the math is completely identical, the second one requires more mental effort. You want to avoid unnecessary decimals. So if precision for the data you're presenting isn't important, just use a 5 instead of a 5.0 or a 4.97. People will process the whole number so much faster. Of course, sometimes you need to use decimals, but if an estimate will work, then go with that. Scale matters. So if you compare 0.5 milligrams to 500 micrograms, so you don't need to know those units, but those are the same amount, right? And if you're trying to compare 500 micrograms to 250 micrograms, people will often find that easier than 0.5 milligrams versus 0.25 milligrams. So don't get caught up in kind of the details of these units, but when you're using units, choose the units that make comparison easier. Use whole numbers, right, if you can. And then lastly, humans like friendly numbers. So our brains like numbers like 10, 25, 80, etc. They don't really like numbers like 0.013, 7.48, 0.0027. Because again, the friendly numbers just require less mental work. Of course, you have to be accurate and you have to, balance accuracy with ease of understanding. Next slide, please. Okay, our third and last principle is provide context. So as we said earlier, numbers by themselves don't have any meaning. The data needs interpretation and explanation. So an example, if I told you someone's blood pressure was 145 over 95, many healthcare providers and people who, monitor their own blood pressure potentially are going to immediately know how to interpret that. But many people have no idea what that means. The number by itself isn't meaningful. It's having the context that is. Next slide. And again, so many things we could discuss here about providing context, but just to give you one example, an important case of the need to provide context is when we communicate really big numbers. So you've probably seen recent headlines about someone becoming the world's first trillionaire. Yay. Sarcasm included. A trillion is such a large number that it's almost impossible for us to understand this intuitively. So we can provide context by translating it into something more familiar. So 1 million seconds is about 12 days, 1 billion seconds is about 32 years, and then 1 trillion seconds is about 31,700 years. Um, or if you want to use an example that also uses money to sort of, trigger those same emotions is, if you were to spend $1,000 every single day, $1 million will last you 3 years, $1 billion will last you 2,740 years, and $1 trillion will last you 2.7 million years. So something like this, I think, really just helps you to comprehend the scale. It makes it much easier to interpret the large numbers. Okay, next slide. This is just another really quick example of providing context. This was a graph that was recently in your local epidemiologist from the CDC. It's just yeah, one example of how you might want to show visual context. There's a million different ways that you can, but I like this because it's very public health, right? It's a recent map showing the cumulative reported cyclosporiasis cases in the US this year. And you can see that like you don't even have to really look at the numbers to get the gist, right? To interpret what the graph is trying to demonstrate. The gray blue curve is showing the historical data, and you can really quickly and easily note that this year in red is on a trajectory and to be, much, much larger this year, right? It's very quick, very easy to make that that association without even looking at the detail. Next slide, please. So let's just quickly recap. So when you're preparing to communicate data, remember these 3 ideas. Know your audience and goal. Are you trying to inform or are you trying to persuade? Reduce complexity. Less is often more. Reduce the work for your audience to understand your data and provide context. Remember that you need to give the numbers meaning. In summary, just consider how you support your audience through their journey from data to action. Next slide. Okay, so we're going to move into the next part of this webinar where 2 of my colleagues from Cook County Department of Public Health are going to be sharing some of the data tools we offer for public use. So first, I'm going to pass it to my colleague, Caleb King.
Thank you, Darcy. Um, um, and good morning, everyone. My name is Caleb King. Um, and I'm an epidemiologist. Uh, with the Cook County Department of Public Health. And today I will be talking about the in the suburb of Cook um in the suburban Cook County Health Atlas features and functionality. Before I begin, I want to mention I'm down a person who stutters, so you will hear some uh, prolongations in words or sounds, and or blocks in my speech, and or and or and or and or um and or repetitions as well. And with that being said, um let's get started. Next slide, please. Next slide. Thank you. Um, in the Health Atlas, um, in Health Atlas, was introduced, in 2022. Um, and it's a collaborative, ongoing, project across, um, in the Cook County Department of Public Health, University of, um, University of, excuse me, University of Illinois, Chicago School of Public Health, um, and Metopio as well, which is a, software, and data analytics, company, who provides um, who provides technical, support and expertise, to the Health Atlas and interfacing platform. Next slide. Um, so on the Health Atlas, so on the Health Atlas, so on the Health Atlas, we report out, data by, um, uh, uh, we report out, data by, population groups or, um, um, population groups, um, and or population groups and or, characteristics, such as age, um, race, ethnicity, sex, and um, in place as well, and to identify, disparities. Um, and we also and we also and we also we report out, in multiple, geographies, shown here, in suburban Cook County, CCDPH, jurisdiction as well. Um, um, in the four health regions, 126, 126, municipalities, 143, zip codes, and, 539, census tract. And I want to note here is and say that, in the suburban Cook County, they exclude, um, 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 and it excludes the city of Chicago. Um, and because they have the, in the Chicago Department of Public Health, in our, uh, in our jurisdiction, it excludes, in Chicago, Evanston, Stickney, and Stokey as well. And because these cities, they have their own, um, many have their own, mental health departments. And we also, um, and we also, um, and we also, we report out, in our analysis by year, um, um, and by year, and or, um, and by year and multiple years as well. Next slide, please. And along with, um, and along with and the several health outcomes um and along with and the several outcomes um you can search for um on the health atlas. And the atlas has multiple categories that incorporate the social determinants of health, such as access to care, health behaviors, socioeconomic status, and other um, 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 and other and environmental factors that affect a person's health, all in one place. Next slide, please. And so on the health atlas, we have two types of data. And the first type um, is the primary data that we collect through our surveys, through the Minnesota Cook County, uh, Minnesota Cook County Health Survey, which is targeted towards adults. And our YBS survey as well, and our youth, um, 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 and our youth risk, um, uh, and our youth risk behavioral survey, which is targeted towards and our youth and high school students. And our second type, uh, uh, um, and our second type is the um, um, and our secondary data that we retrieve from a state agency in the Illinois Department of Public Health. We retrieve in our um, birth, death, and hospital discharge records from them. We also um, and we also um, uh, um, Um, and we also retrieve Medicare enrollment data from the Illinois Department of Healthcare and Family Services. And we also and we integrate um, and we also and we integrate and the data sources and from the CDC in the US Census Bureau as well. Next slide, please. Um, um, uh, and we also have an opportunity for you all to be trained in the Health Atlas um, trained in the Health Atlas as well outside of this webinar space. Thanks to in the UIC School of Public Health and the Epidemiology Unit. Um, um, uh, and the community health, um, 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 and community health, health education, unit as well, um, uh, and several other, um, and several other, and several other community-based organizations work together to create this Health Atlas training program. Next slide, please. And the target audience for this program is very inclusive. Um, You don't need to be an epidemiologist, um, um, uh, or data analyst. You could be a community member, um, um, or a person who's interested in um, or a person who's interested in understanding um, um, or a person or a person who is interested in understanding data, um, um, you don't um, uh, uh, you don't need to have any formal public health trainings, um, any formal public health training to be um, 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 to be able to participate. Uh, Next slide, please. We also have a toolkit that we created. And so feel free to skim through and to get a better idea of the program. Yeah, and feel free to email me if you're interested. Um, if you're interested. Um, um, uh, if you're interested in joining the in the Data Ambassadors program. Next slide, please. And so um and so and so we will shift gears to in the Health Atlas demo where I'll showcase how to use the Healthlet um um where I'll showcase how to use the Health Atlas to be able to use um and to use and create uh um graphs and maps and tables as well. And I will be using cancer mortality as my example. Next slide. And so in this pie chart, um 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 uh uh and so in this pie chart, we are taking the accounts and the people who have and the accounts of people who have passed from cancer. And so as we see here, 68.6% in our white um um and so and so um um many of our white residents have passed from cancer. Next slide, please. And in this graph is the area line chart. Um, and it shows the trends. Um, uh, um, and it shows the trend and the percentage of um, and the cancer deaths over time. Um, um, and by race ethnicity, and the shading, um, uh, and the shading, and/or fill, um, and the shading and/or fill, and below each line graph, or line, um, um, and it represents and the quantity of um, in a quantity and or volume of the cancer deaths per race ethnicity group. Next slide. And now we're seeing a bar chart. Um, 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 Minister Cancer, uh, Minister Cancer, uh, Ministry Cancer, uh, Minister Cancer mortality rate. And we take into account um, and the population estimates, um, and the population estimates a drop from the census data. Uh, um, um, and so in this chart, um, um, and so in this bar chart, we can see that uh, um, in our black, um, in our black, um, in our black, um, um, in our black, uh, in our black, uh, excuse me, in our black residents, they are being disproportionately and affected across all um, and across all race and ethnicity groups. Um, and next slide, please. Um, and here, um, in here, is a line chart. And it shows the trends and the cancer deaths from 2010 to 2024. Uh, so as we can see, Black residents um, and they consistently have the highest um, um, and they consistently have the highest cancer death rate. Next slide, please. And you can also show these right. Um, um, excuse me. Next slide, please. You can also show these. Um, uh, you can also uh, you can also show these rates in the map as well. This is a default map that in the Health Atlas shows. And so as we can see, in the red areas have the highest burden of in the cancer mortality rates, and the blue areas have the lowest burden. But I will change the in the color scheme so that it's easier to read and interpret. Next slide, please. Um, and so here, um, and so here, um, 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 and so here, I made the color more, I made the color more, uniform. And the lightest purple have the, and the lowest burden, while the, um, and the darker hues, and they have the highest burden. And with these maps, you are able to pinpoint areas as far as like your health campaigns, um, um, or your programs as well, and to target these um, um, and to target these in these high burden areas. Next slide. And I will pass it to um, and I will pass it to Kelly to go. Thank you.
Thanks, Caleb. Hey, everybody. I'm Kelly. I work in our communicable disease program here at the Cook County Department of Public Health. I'm our program manager for surveillance and informatics, which means I do a lot of different dashboard development. And in particular, my expertise is in seasonal surveillance. So I'm going to be showing a couple of visualizations from our seasonal dashboards and talking about how we apply some of the principles that Darcy was talking about in our surveillance work. Next slide. One more, Nancy. Thanks. So before I dive deep into seasonal surveillance, I wanted to just do a quick orientation around what that concept is. Many infectious diseases have seasonality, which essentially just means that the cases occur in regular patterns throughout the year. So I've shown one example here on the side of Salmonella, and you can see how there are these regular waves where cases increase during the summer and then they kind of drop again during the winter. Next slide. Some diseases have more seasonality than others. There are infectious diseases that we monitor where the majority of the cases are reported in just a few weeks or just a few months out of the entire year. So here on the screen now, we're looking at a disease that has a little bit more seasonality. This is for influenza. In particular, these are intensive care unit admissions. And you can see those waves are even more pronounced than they were for Salmonella. Next slide. So for these diseases that have high seasonality, it really makes a difference when we want to deploy interventions that reduce transmission. We don't want to implement interventions when there's no disease actually circulating. So we really want to understand when those seasonal waves are starting to pick up and when they're going down. So here I've just added some notations to show, one of the things we do for flu is we ask hospitals to implement temporary visitor restrictions. Those can be not enjoyable for the people who are actually in the hospital and want to see their family members. So we really only want to do that when we actually have cases, not when there's nothing going on in the summer. Next slide. We also might make decisions about what interventions we want to layer on top of each other. So some interventions can be more intrusive for the public than others. So here again, I've noted in the 2025 flu season, that was an especially bad flu season. So we might consider making a recommendation for members of the public to wear a mask if they are so inclined. That's probably not a recommendation that we would make during, for example, the 2022 season when case counts were much lower. Next slide. So I hope that kind of gives you an idea of why we do seasonal surveillance. And now I just want to talk about how we actually do seasonal surveillance. What we do is we look at data in near real time on a regular cadence. So essentially every single week, we're looking at the data and getting a sense of what is happening on the ground. And we're publishing that data in weekly surveillance reports and dashboards. The two main areas where we do this for Cook County is in the area of respiratory disease. Our respiratory dashboard, we really focus on that during the winter season, but we actually do update year round because COVID will often have a summer wave. So every week we are putting out data. And then for West Nile virus, we have a focused surveillance dashboard that we update every week throughout the summer. So I'm going to be showing some examples over the next few slides from those dashboards. Next slide. Before I do that, though, I want to put a little bit of context around seasonal surveillance. When we are looking at data in near real time and we're making frequent updates, kind of an inherent byproduct of that process is uncertainty. Data is still flowing in, numbers are expected to change, and so we're trying to get a read on what is actually happening on the ground, knowing that what we're looking at is an incomplete picture. And so that affects the choices that we make when we're displaying data. Next slide. So in particular, I want to highlight just kind of a few principles that we kind of use as our guideposts when we're doing our dashboard and report design. And you're going to hear a lot of the same concept that Darcy was talking about echoed in the principles I'm about to walk through. Next slide. The first thing we do is we look at multiple sources of information. Next slide. So here what we're seeing are some screenshots from our respiratory dashboard. These are all for COVID. The details aren't really important, but what you can see here is we've got emergency room visits, we've got ICU admissions, and we have wastewater concentrations. But all of those different lines or bars, they all have kind of that same shape. So when we have these multiple graphs all following that same trajectory, it can make us feel a lot more confident about the messaging that we're putting out to the public and to our stakeholders. Next slide. The next thing we try to do is compare all of our data to something familiar. So if I say to you that we have 30 ICU admissions for flu per 100,000 people, as someone who is immersed in the data every year, that means something to me, but that's not going to mean something to most people who are looking at our dashboard. What might mean something to them is if we say we're seeing double the number of admissions for flu than we were last season. So we're always trying to put that data in the context of something familiar. So to see what that looks like, you can go to the next slide. I want to start with showing you our West Nile virus dashboard. So West Nile virus has, again, seasonal waves every summer, but some years are worse than others. The transmission is kind of more extreme. We call those years outbreak years. And so on our West Nile virus dashboard, we have the ability to turn on and off comparisons for different seasons. We always include the most recent seasons, and we always include the last outbreak year. So it's very easy to visually compare how is this season looking when compared to a very bad season. Next slide. And then on our respiratory dashboard, this is RSV, emergency room visits. By default, all of our graphs are with the current season and the immediate past season. So users would have to kind of make changes to change that default vision. Always shown in red, the past season, always shown in blue. So again, your eye can kind of very quickly see how is this season stacking up to the last season. Next slide. The other principle we always try to keep in mind is borrowed from public health risk communication. I'm not sure how many of you are familiar with this concept of SACO. It stands for Single Overriding Communication Objective. So essentially, what is the one thing you want your audience to take away from? And we try to put that one thing for us up front on all of our dashboards. For West Nile virus and for respiratory, that one most important piece of information is going to be the risk or the activity level. So going to the next slide, Nancy. Here is the landing page for our West Nile virus dashboard. There's a lot of text on this page, but you can see that some text jumps out. It's in that box that's distinguished by color. We have the risk level at the end in bold. And then on the next slide, Nancy. We do the same thing on our respiratory dashboard. So you can see your eye kind of immediately goes to those boxes of color, and those are the activity levels. That color is not arbitrary. It changes throughout the season according to kind of a spectrum that also tries to underscore that risk level visually as well. So it kind of goes through some lighter colors up into some oranges and deeper purples, depending on what we're seeing on the ground. Next slide. So as Darcy said, you also always want to consider your audience. This has been a challenge for us over the last several years with our respiratory dashboard in particular, because the audience is broad. When we first started putting out data pre-pandemic, we were primarily speaking to healthcare audiences, and so we were very data focused. But when the pandemic hit, a lot more people started using our dashboard, members of the public, members of the media. And so now we know that we're speaking to a very broad audience when we put out data. So how do we kind of speak to all of those different audiences at once? Next slide. Again, this is the landing page for our respiratory dashboard, but what I want to highlight here is, like I said, we have those activity levels. That's where your eye goes first. But then right next to it, we have our key points. So here we're kind of summarizing the data so that if you don't really want to dive deep into kind of all of the different graphs, you can just read those couple bullet points and you're going to walk away with a pretty good understanding of what's happening on the ground. But if you are somebody who is more invested, who really wants to see the shape of the data, Then you can click through those tabs along the top and you can see everything that we're seeing. It's really important to me for transparency that every piece of data that we're using to make recommendations and decisions is also available for viewing. But we've kind of designed the dashboard so that you're not overwhelmed with all of that data the minute you hit the page. Next slide. The other thing we try to do is work with our partners to kind of repackage that information and to be sure that it's kind of serving double duty wherever possible. So on the left side of the screen, you're seeing our West Nile virus dashboard. This is one of the maps on one of our tabs. So for people who, again, want to go digging, want to dive deep, you can hover over all of those red circles and see exactly kind of where that trap is located, what was the date that it was last positive on. The box on the other side, if you click play, it'll play a little animation so you can kind of see how the season is progressing. But then our lovely comms team, credit to Nancy who's advancing the slide for us today, takes that same image and repackages it into this lovely graphic that can be easily sent out on our social media channels or shared with our partners and newsletters. And so that same data is kind of serving multiple audiences with just some slight retooling. Next slide. And then the last thing I want to leave us with is that we always try to, again, connect our data to action. I think that's always important, but I think it's especially important when the data itself is uncertain, because our subject matter experts, we have a little bit more of an understanding of that data. So, I have a better understanding of, is this particular data source a leading indicator or a lagging indicator? Is this something that it tends to be more accurate or less precise? And so making that leap for our audience that may not have that level of familiarity, okay, this is all this data, but what do I do with it? We want to make sure we're telling them, here's what we think you should do with this information. Next slide. So again, that landing page for our respiratory dashboard, you can see activity level, key points, but also recommendations. And so that recommendations bullets, that's something that we're looking at every single week. Some of it is standard because we should always be covering our cough, but we will add additional bullets throughout the flu season when we think it's appropriate for people to be making additional protection steps on top of those general respiratory hygiene. Next slide. And we do the same thing our West Nile virus dashboard. So we have a special tab explicitly labeled, how can I prevent West Nile virus? So that anybody who's looking at our data, they're going to be led straight into, okay, now what do I do with this information? How do I protect myself? Next slide. So again, just to very quickly recap those principles, incorporating multiple sources of information, but comparing it to something familiar, using SACO to get your most important information out to your audience, but bearing in mind that that audience might be different and how can you tailor that information to each of them, and always giving that action step. And I think I am handing it off to Melanie next. Thanks.
That is correct. Thank you so much. I have learned so much from all of you today. I'm Melanie Sampson. Hello. I've been working with the Cook County Department of Public Health team on this webinar series. I'm just going to kind of wrap us up, and then we will turn off the recording, and we'll have a little bit of time left if anyone has any questions or has resources they want to share. Next slide, Nancy. So big thank you to our guest speakers. Our tried and true presenter, Darcy, we're wonderful information. And Caleb and Kelly, we're so grateful that you were able to come on and share your real life experiences, sharing information and data with everyone, as Kelly mentioned. So thank you so much. And thanks for sticking around. Next slide. I just want to let you know that next week, Darcy will be sharing out resources. So we do have, next slide again, Nancy. We do have the, all of these tools that I'm showing on the screen right now are going to be available in that link that we shared, as and Darcy's going to email them out again as well. So we have a video that's a short little little overview of thinking about readability beyond just kind of, sometimes it can be easy to fall into the trap of just assigning grade level. So what are other things that aren't always captured in that can be super helpful? So a little quick overview of some plain language principles in that video. We also have an adaptable tool that our team worked on with Caleb to think about how do we take those ideas from the Cook County Health Atlas and think about the Suburban Cook County Health Atlas and then apply them to real life needs in your organization. So you can check that out. And then there is a brief survey. We always love to hear from all of you how you're using either the toolkit or any of the resources that we've shared. Next slide. And heads up, this is a 6-part series. Hopefully, if you haven't been able to join some of our other webinars, you've been able to watch them online. Sorry about that. Just 1 second, I got a little technical difficulty. Can't so much. There we go. We have our last of these webinars coming up on September 18th. So please join us for that. The theme is community engagement and outreach, and you can find all of the past webinars on the CCDPH website. Next slide, Nancy. Again, this is that same QR code from the beginning if you want to check out those resources or save that so you can go back to it and link to all the things we just talked about. They will all also be listed on the CCDPH website. Next slide, Nancy. I think we have all those websites that Caleb and Kelly mentioned listed here and on the resource document, so you can check those out. And then also the next slide has contact information for Darcy, Caleb, and Kelly if you want to touch base with any of these wonderful public health folks about their work. So we will wrap up this portion of the webinar. And then if you want to stick around, we'll have a chance to ask some questions. So thank you so much for joining us today or watching at a later date.